Good morning, everyone. My name is Dr. Jessica Hopkins. I'm the Vice President and Chief of Communicable Disease Control at Public Health Ontario. I am absolutely thrilled to welcome you all to our Topic 2026 virtual convention. It's my great pleasure to be moderating our plenary session entitled Modern Tools, Healthier Communities, Artificial Intelligence Insights Shaping Public Health Transformation. Before we begin, a few housekeeping notes about how the session will be conducted. We will begin with a discussion amongst panelists, followed by a question and answer period. To ensure an engaging and optimal experience for all, we've disabled the Zoom chat and audio-video features for this session. Please feel free to submit any content-related questions in the Q&A function, which you can find at the bottom of your Zoom window. We'll do our best to address these during the discussion period. If you have any technical issues, please email topic, that's TOPHC, at oahpp.ca. Today, we are privileged to be joined by a distinguished panel whose collective expertise and insights will greatly enrich our discussion. This plenary session brings together leading voices in Canada's AI and health innovation landscape to explore the transformative role of AI in shaping the future of public health and beyond. This session will offer a forward-looking conversation leveraging the panelists' experience in AI deployment in complex health environments, advancing predictive analytics and AI-enabled public health tools. The discussion will also explore the intersection of clinical AI, health equity, and the environmental and ethical implications of AI systems. Our first guest panelist is Dr. Kyle Wilson. Kyle is a senior public health leader at Wellington Dufferin Guelph Public Health, specializing in digital transformation, data governance, and responsible AI adoption. He brings over 15 years of experience advancing health informatics, privacy, and innovation across Ontario's public health system. Kyle is an adjunct professor at the University of Guelph, a lecturer at the University of Waterloo, and an associate member at Toronto Metropolitan University. His work is centered on leveraging technology to reimagine processes for maximum efficiency, ensuring public resources are used effectively and deliver great value. Next, we have Dr. Damian Yankovic. Damian is the Executive Vice President, Chief Information and Artificial Intelligence Officer at Unity Health Toronto, where he oversees all aspects of information technology, AI, decision support, diagnostic imaging, and laboratory medicine. Damian holds a PhD from McMaster University, specializing in artificial intelligence, machine learning, and computational modeling, and has a deep commitment to advancing AI's role in healthcare. As an adjunct professor at the University of Toronto, he teaches health informatics, contributing to the education of the next generation of healthcare professionals. In 2021, he was honored with the International HIMSS Changemaker in Health Award for his efforts in leveraging information and technology to transform care and research. And finally, we have Dr. Rowan Abulabde. Rowan is a postdoctoral researcher at the University Health Network, Transform HF, and a recent PhD graduate from the University of Toronto. At UHN, she leads work examining the environmental footprint of artificial intelligence in healthcare and supports the development of practical guidance for responsible implementation. Her research bridges technical AI development with questions of equity and oversight, exploring why AI systems can fail different communities and how health systems can detect and address those risks in practice. She collaborates across Canada, the United States, and internationally on research and education initiatives advancing trustworthy and sustainable healthcare AI. And with that, let's jump into our discussion. So, where I'd like to start with our panelists is just take a couple of minutes and tell us, from your perspective, what is the most important way artificial intelligence could help local public health and the communities they serve over the next few years. Kyle, let's start with you.
Thanks. And first, thank you for having me today. Very excited for the discussion. Uh, I'm thinking, so AI and other technologies are becoming much more difficult to ignore. There's certainly a momentum. The momentum is real. The tools are becoming more accessible, more embedded in everyday work, and more expected, not just in healthcare, but across the public sector and certainly across the private sector. And what's exciting is it's not just about advancing AI. We're seeing a much broader adoption of technology, including relatively simple automations that drive real efficiency gains at an operational level for the various public health units. So it's the opportunities here is not just about innovation for innovation's sake. It's about using these tools to reduce administrative burden, streamline workflows, allow staff to focus on the work that really impacts the communities, directly impacts the communities. That's where I see the biggest impact. It's not about replacing what we do, but it's really about enabling us to do it better, faster, at greater scale. And I think as the adoption accelerates, I think we'll see a shift from sort of isolated pilots across the various public health units to something that's much more embedded across public health operations day to day.
Thanks, Kel. I love that. I mean, the idea of being able to do the work in communities better and more effectively, I think is fantastic. Damien, let's bring you into this conversation and get your perspective.
So maybe I can start with a couple of examples of AI that we've implemented in healthcare and how I think that translates into public health. So, for example, on our internal medicine units, every patient is monitored by AI. AI is actually monitoring the electronic health record of the patient, looking at labs, looking at notes, looking at the kind of information that's streaming into that electronic health record, and makes a simple prediction. Predicts whether somebody will go to intensive care unit within the next 48 hours, right? And if the model predicts that, we have a whole set of protocols that are enabled. They're quite generic, actually, the protocols, to be able to kind of more proactively deal with the patient. We've shown that, first of all, clinicians are terrible at this, at making these predictions. And we've also were able to demonstrate that this kind of approach reduces mortality by 26%. So imagine that. It's actually saving lives. But what you're seeing is kind of shifting from reactive to kind of versus proactive approach. Another example, if you have a head injury and you happen to be taken to St. Michael's Hospital as part of Unity Health, and you have a CT scan, the first thing that will read that CT scan is actually AI. And AI will prioritize that sort of reading of that image for our radiologists. Instead of going into a regular queue that might be an hour, for example, it will prioritize it to the begin to the kind of to the top of the list so that the image is read quickly because the model is predicting whether you have a brain bleed or whether you have traumatic brain injury, right? So again, we're trying to kind of shorten the time and being a more proactive rather than kind of reactive when everybody knows brain is time in this kind of a case, right? So from my perspective, public health is the opportunity. There are lots of opportunities, as Cal has mentioned, but the one that I'm most exciting about is moving from this kind of a reactive approach to problems to anticipating them. So public health has always been about prevention, equity, and sort of seeing this larger picture. But I think what AI is really starting to offer is being able to detect these patterns, detecting risks, and these kind of unmet needs in different populations that you're looking at a speed and scale that just has not been seen before, right? So, you could identify emerging threats much more quickly, better understand where you have emerging kind of chronic disease or mental health burdens. How do we apply some of these things more kind of interventions much more precisely? So I think just as the hospital level, I'm kind of very excited about building an intelligent, responsive, and anticipatory hospital. I think at the kind of a larger scale, I'm excited about public health becoming the sort of intelligent, responsive, and anticipatory public health system. You can see more clearly, you can act earlier, you can target interventions much more effectively. And I think as some of the opening remarks, this does not replace the human judgment, right? The human judgment is always kind of working with AI to support that. But I think the speed and scale that public health will be able to achieve going forward will be just unprecedented.
I mean, this is great. You've given a couple of really good examples that I think can help us in public health. Like you talked about, like large amounts of data that is getting processed to help make these predictions, and the whole idea of prevention. Like that is absolutely something that resonates, I think, with us in public health. Rowan, what about you? What have you got to say on this question?
So, one of the most important ways that I think AI could help public health is by actually changing what our healthcare systems are able to see. Because in public health, what we're able to see is actually what ends up determining what we end up acting on, and ultimately who are the groups of people that are getting served. Public health has always relied on data to guide decisions, but in this sense, our systems inevitably end up simplifying reality because they highlight some patterns while leaving others completely invisible. And these gaps are actually not random. They tend to reflect long-standing patterns in whose experiences are captured well in health systems and whose are not. And this is where I think AI's most important contribution lies, helping us finally reach the communities that our current systems have consistently missed. It can detect patterns early, it can understand how social and environmental conditions interact with health, and it can also design prevention strategies that can reach the people who need them most. So, in that sense, it can expand the scope of what public health is able to anticipate and to respond to. But what makes AI particularly powerful is actually also what makes it very complicated. These systems learn from historical data, and that data reflects how our health systems have been functioning over the years. And I think about this constantly in my research because without deliberate attention, we risk not just using AI to understand inequalities, but embedding them more deeply into the tools that we rely on. And this is where I think public health has a uniquely important role to play. Public health has always been concerned with population health, prevention, and fairness across our communities. It brings a way of thinking that looks beyond individual outcomes to patterns across populations. And that's exactly what is needed when these systems are being introduced. So the opportunity for public health isn't just to adopt these tools, but it's actually to shape how they're designed, evaluated, and governed. And to do that in a way that actually ensures that these systems don't just make health systems more efficient, but actually ends up making them more equitable.
So I love that you've brought up, the what are the safety, kind of the safety features that we need to be thinking about when we are implementing AI. And I think it's great that we're having this conversation now because overall, I think public health is at an earlier stage than some other sectors in terms of AI adoption. So good for us to be building this in, is what I'm hearing from the start. So I'm going to dig in a little bit deeper and move to some individual questions for our panelists. I'll go back to Kyle again. So you're working in a local public health unit. You are at the front line of public health program and service delivery in your community. And you've already talked about how AI is rapidly becoming a part of everyday public health practice. So, from where you're sitting, where are you seeing AI offering real practical value right now? And what can health units learn from early successes?
Thanks, Jessica. So the sort of real value right now is around the practical operational use cases. When you think of AI, some people think of these big theoretical systems and fully autonomous agencies, but it's really how do we implement these practical, useful operational systems currently in the current environment. So at WDG Public Health, we focused on using AI and I'll put automation in that bucket. So AI and automation to improve workflows, reduce burden, enhance service delivery. A few of the projects that I know some people on the call certainly have heard about and are collaborating on. So use of AI scribes, use of AI chatbots with our collaborative with Simcoe and Southwestern, exploring AI agents and how AI agents can be used in conjunction with staff, automating significant parts of the ISPA project process, or we call that the VIPER process, the Vaccine Immunization Public Epi Registry process. And I know a lot on the call are going with us in that collaborative initiative. Working on safe water automation to be able to extract data, process data, and move towards SMS-based notifications. Immunization communications through QR code based forms with auto population of data, and then just most recently VaxLink. So VaxLink actually does scanning of barcodes on vaccine for automatic data entry into Panorama or your EMR in question. So I think it's important to realize we're not doing these as sort of one-off pilots. We're looking to collaborate on all these initiatives through the Public Health Innovation Zone or phis.ca, so phiz.ca, to create a structured way to test, scale, and share these solutions across the province and incorporate any and all solutions that any public health unit is doing across the province on that website, on that collaborative platform. We're investing in foundational resources. We're expanding the data science team, hiring data engineers, partnering with AI for public health, bringing trainees, fellowships. We're actually hiring for a couple data engineers in the coming weeks. So a plug to those listening, if that's an interest of yours, certainly look out for the job posting. And I think the biggest lesson for everyone, including ourselves, is start with real problems. Focus on the workflow improvements, build incrementally, because the most valuable AI right now isn't about being the most advanced. It's about using these tools that are just quietly saving staff time every day.
That's really interesting, and I love that you've created like what it really sounds like a tapestry of different tools, solutions that you can use and incorporate, and really build on partnerships to be able to do this as well. So I think some great lessons learned in there. Um, Now, as we look at adopting new technologies, I think one of the things that we have to be really mindful of, and Kyle, you spoke about this, is, it's really centered around people and how this helps support people working in local public health. So we need to make sure our public health workforce is going to be well equipped to be successful. So, Damien, I want to draw on your experience as the Chief AI Officer at Unity Health. What can we learn from you about the skills and competencies that our professionals are going to need to develop? And, I think that hospitals are such busy places. I'm really curious to understand how you've been able to implement this in a busy hospital setting where you've got lots of competing priorities and demands.
So, maybe I should start by saying that I think the goal of education here is not really to turn public health professionals or health professionals into data scientists and AI engineers, right? Like, so we should state that. But it is to make the kind of all of us more confident to ask the right questions, kind of understand the opportunities, kind of use these tools meaningfully. So I think that's important. I do think you have to start with basic AI literacy though, and kind of the practical understanding of AI can or cannot do, and where caution is kind of needed, and where you should apply it more broadly. We've tackled that through developing Health AI Academy. So we actually deployed a Health AI Academy, and please, if you want to take a look at it, LinkedIn, it's actually a national program that we've developed for healthcare professionals around AI to build not only this kind of a basic level of AI literacy, a little bit more than that, but I think that's where you have to start off with. I think, then really there are a couple of other things that you really need to kind of build capacity or skills in. One is critical judgment, right? Like, how do you use these tools? And when we deploy these tools to our radiologists, for example, we find that sometimes they over rely on these tools. Sometimes they under rely on these tools. And it's not perfect science, and it depends on the kind of tool that you're using. So there's this critical judgment set of skills that you really need to develop with clinicians. And then finally, it's all about change leadership, right? Like these tools at the end of the day, tools that have to be adopted by clinicians at the front lines, that are actually used within workflows, trusted, and those couple the critical judgment piece and the leadership piece, we actually do as we deploy some of these solutions, right? We have clinicians involved every single step of the way as we do that. So, naturally, we build trust in the process. Naturally, we build trust in these tools, and kind of we train. Training comes along as part of this kind of a deployment, because a lot of these tools can be very specific, and how you deploy them, is kind of sometimes a matter of life and death.
I mean, I think you've really spoken to like the process of this. This isn't a switching a tool on and off, and suddenly it's on your computer and things are going to work in a different way. But that, it sounds like you had a really deliberate approach where you have education and also where you brought people along the journey as well as part of that change leadership to make sure there's buy-in, understanding, and build up that trust over time. So I think those are some good lessons for us to be thinking about in public health as we start to roll out AI solutions. Rowan, I want to really pick up on some of the things you said earlier related to equity. Public health strives to improve the health of communities, and your work focuses on the ethical and equity implications of AI in health systems. And so I think our audience, like public health units, policymakers, clinicians, would be really interested in practical steps they can take to ensure AI tools reduce inequities rather than reinforce them, especially in communities that, as you mentioned, have been historically underrepresented or misunderstood in health data.
So thanks, Jessica. That's a really important question because AI systems don't automatically reduce inequalities. In many cases, they can actually unintentionally reinforce them if we're not careful about how they're designed and deployed. So I usually think about this in three areas where public health institutions can act. Obviously, there's so many more that you can find in the literature, but for today, I'm just going to focus on three. So the first one that I think about is representation. AI systems, they learn from historical data, and in healthcare, those data sets often reflect long-standing gaps in who is measured well and who is not. So certain communities, including rural populations, indigenous communities, newcomers, or people who face barriers to care, are often underrepresented in health data. If those gaps exist in the training data, then the systems that are built on top of them may perform less accurately for those groups. So, one practical step is to actually start asking questions about the data behind these tools, like who is represented, who is missing, and how that shapes performance across these different communities. The second one that I think about is evaluation. Many AI tools are evaluated primarily on overall accuracy, but an algorithm can perform well on average while producing very different outcomes across different populations. Public health units and policymakers should be asking whether these systems have been tested across different demographic groups and whether their impacts are monitored once they're deployed in real world settings. And finally, the third one that I think about is governance. AI systems ultimately shape decisions about how resources are allocated and which health risks receive attention. So, in that sense, governance isn't just about oversight, it determines whose needs are prioritized in the system. But governance alone isn't about processes within institutions. It's about who has a voice in how these systems are designed and who benefits from what they produce. So, communities whose data is used to train these systems should have meaningful input into how they are governed. The principle of consent and benefit sharing is something public health already understands through its community engagement work. It just needs to be extended into AI. Public health has a long tradition of thinking about prevention, equity, and population health. So, bringing these principles into how we evaluate and govern AI systems will be critical to ensuring that these technologies actually reduce disparities rather than quietly reproducing them. Because technology alone doesn't determine outcomes, the governance does.
That's so interesting. I love how you've broken that down into sort of three areas: the representativeness, evaluation, and the governance. And I can almost imagine a process of when public health units or other public health organizations are looking at adoption or creation of different tools, like embedding some of these themes from the start so that you actually have a good understanding of the impact you might actually have and make sure that you're having a positive impact on all of the groups that you're looking to serve with that. So I think that's some really great practical ideas for us to be thinking about. So I'm going to open the next question up to any and all of the panelists who want to respond to it. So AI is, I think it's really interesting. It's enabling innovation in health systems and doing things that I think many of us, maybe not all of you, but certainly some of us who don't work in the AI space all the time wouldn't have imagined 5 years ago. I was recently reading about, for example, Agent Hospital in China that uses AI doctors to autonomously diagnose and offer treatment. So where do you, or do you think that the expectations that we have of AI may be getting ahead of reality? So I'll just open it up to whoever would like to start.
I can jump in. I've been starting throughout. So I think that we talked a lot about stages of AI or use cases where I think the expectations are getting ahead of reality if we just jump straight to fully autonomous systems and talk about nothing but that sort of scenario. I think in public health, real value right now, much more grounded in supporting workflows, improving data quality, augmenting staff with the use of AI. But I also think we have to think about risk and maybe reframe how we talk about risk. I find the tendency in public health and the public sector is we assume the current way we're doing things is always the safest. It's the lowest risk because it's familiar, it's the way we've always done it. But I'd like to argue and push the viewers. Maybe that's not always true. There's a real risk of non-acting, of not changing. We don't adopt some of these tools, improve efficiency, responsiveness, data use, we could fall behind and ultimately not be serving our communities as effectively as we potentially could be. At the same time, there is the other side, moving too quickly without the right foundations, data quality, governance, oversight also creates risk. So when we think about risk minimization, the goal isn't to rush or to resist. It's really to move deliberately in a direction to improve quality and improve the lives of the individuals in our community. Focus on high value, lower risk use cases, build strong foundations, scale responsibly. And I think the real risk in public health isn't about just getting AI wrong. It's about missing an opportunity to use it to really make a meaningful difference.
Okay.
Just,
Anyone
just
else
me,
want to jump in? Yeah, go ahead,
sure.
Damien.
Just maybe just after that, I completely agree with Kyle. I think first of all, I think AI is moving at a speed that for those of us who track it is in just incredible speed. There's another revolution that's happening in AI around kind of agents and those kinds of systems. But I think the real gap between expectations and reality is around we're seeing these impressive demonstrations, but we're not seeing a lot of safe real world deployment, right? And I think that's a real. So even the hospital, Jessica, that you've mentioned is really about testing autonomous agents and so on, but it's really not treating any patients, right? So I think that the kind of moving from this kind of these incredible demonstrations to messy world, and that's where we focused on, where Unity focused on, how do you deal with messy data, messy workflows, lots of variability, and how you embed AI in those kind of real world deployments is actually not trivial. And moving from one to another, even from research, which again is dealing with clean data, kind of very pristine environments, controlled environments, to real world deployment where anything can happen, that's been the real gap. And I think we really need to push this gap in Canada as much as possible because I think we're falling behind other jurisdictions in this space.
So, if I could also jump in, I think one place where expectations are getting ahead of reality is in how we define value. We tend to evaluate AI on technical performance like accuracy, efficiency, and scalability, but those metrics shape what we pay attention to and what we overlook. And when we scale AI across healthcare, that scaling has real costs. Things like more infrastructure, more energy use, and the list goes on. And what we need to keep in mind is that those costs are not evenly distributed. They often fall on communities that are already bearing disproportionate environmental and health burdens. So that part of the equation is almost never part of the conversation. And like I said before, accuracy itself can be misleading. A system can perform well on average while producing meaningfully worse outcomes for specific populations. And if those populations were already underserved, we've used advanced technology to deepen an existing inequality. So the gap that I worry about most isn't between what AI can do and what people expect. It's between how fast these systems scale and how slowly our institutions develop the governance to manage them responsibly.
So I think this is a great segue into, because I've been keeping an eye on the questions that are coming into the Q&A section. I want to pick up on one of them that I've seen coming in, and Rowan, I think this is really for you because you started to touch on it just now in your answer. Negative environmental harms that can be caused by some of these big data centers, and the negative impact on our vulnerable communities. Can you talk a little bit about that and ways we can reduce the negative environmental impacts?
So I mean, it's pretty hard to think about it at scale because right now a lot of the conversation talks about just kind of the energy use of AI, but there's an entire life cycle process that we need to keep in mind from the development of them to when we're finished using them. I think we first need to think of principles into how we are able to assess AI in the environmental aspects of it in the sense of healthcare itself. There are already principles to look at the life cycle assessment of AI technology. They're not actually legally mandated yet. So, like that would be a great place to start, but healthcare itself is its own sphere. There are also a lot of aspects that we need to keep in mind for patient safety. So creating an entire life cycle approach to be able to assess the environmental impact would be the place to start, because we literally don't have any quantitative data on that yet.
That's great. So it sounds like more to follow in this area for us to learn about. So I think our discussion's been really interesting. I want to make sure that we're bringing our audience into this as well. So audience members, please feel free to put any questions that you have into the Q&A. We'll try to get to as many of these as possible over the next little while. One of the questions that we have is, we hear a lot about AI's role in diagnosis, treatment, and risk prediction. How can AI meaningfully strengthen health promotion, particularly the social, environmental, and policy conditions that support well-being, without reinforcing inequities or shifting responsibility back onto individuals? Open to anyone on the panel.
No, maybe I could just say, from a practical perspective, these have been very difficult questions to answer. And partly is because we don't collect a lot of data around to address some of these inequities, right? Like, so I think that's part of the issue that we're finding sort of on the ground as we're deploying some of these tools. We simply, as a system, don't collect data that can allow us to assess these questions, right? So then it becomes a kind of a risk valuation approach. How risky is it to deploy a tool versus not deploying a tool at all, right? And I think we just have to be really, that's become, and when you practically start deploying these tools, that becomes a real challenge, right? There's some, as I've mentioned, some of the tools we're deploying, we're saving lives. Is that a risk we're willing to accept? And I think that's when you start deploying some of these tools in real world settings, it becomes quite challenging. You're starting to realize the gaps that we have in the data, that it's hard for us to evaluate some of the issues that people are raising in a kind of from practical sense.
And
If,
maybe Jessica,
sorry.
if I could add, having equity embedded from the outset, so it's not treated as an add-on or a bolt-on, much like we do privacy impact assessments when we go through for anything that we deploy, any software solutions, anything new at the agency, go through an equity impact assessment to do an evaluation to determine sort of those challenges or those items that need to be addressed from the forefront before something is actually deployed. Sorry,
Excellent.
Rowan.
Great reminder.
It's
Rowan.
Yes, sorry. So I just wanted to add that I think when we are talking, because a lot of people talk about like the benefits of AI, but we need to ask like the benefits are for who? Because there has been a lot of disparities that we've been noticing when we are testing these AI systems. So I think one practical way is for us to focus on regulation. And this is where I think Canada has a genuine opportunity. Right now, many AI tools enter Canadian health systems largely on the basis of FDA clearance, or they don't need any type of clearance at all. But FDA clearance wasn't designed with Canadian public health context, with our Indigenous communities, or Canadian equity frameworks in mind. Public health leaders should be actively shaping how these systems are governed here, not waiting for frameworks designed elsewhere to be handed to them, or allow AI to enter our health systems without proper clearance first.
Excellent. Our next question is about the role of AI as a workforce support tool for public health unit staff. And the example they give is using Microsoft Copilot to support nurses, dentists, inspectors, and corporate staff with documentation, analysis, and administrative burden. And where do you see the greatest near-term value or limitations?
I can start again. For me, it comes down to trust, and the trust starts with the workforce. So if staff don't understand how AI is being used, don't feel confident in it, don't have trust in terms of the senior management, the direction that it's going, it's difficult for it to be implemented and accepted broadly at an agency. So leaders really, I think, need to position AI as an enabler, not a replacement. So something that supports people in doing work better. We're trying to approach it exactly in that way at WDG. We're developing a tool called Loopistry. So Loopistry is a human-in-the-loop AI platform for sensitive workflows. So it sits locally in the data center, and it's around stitching together both human expertise and AI is the tagline. And AI helps generate structured outputs, but people remain responsible for reviewing and validating every data element with clear links back to the source evidence, keeping sensitive data within our own infrastructure through local deployment. So it's an on-prem or on-premises solution. And the goal is not just about efficiency, it's safe, scalable, trustworthy AI. Because if we get the trust right, with both staff and members of the public, I think everything else becomes a lot easier, becomes possible. And that's really the balance we're trying to navigate, moving forward thoughtfully, but not standing still, certainly. And we've talked a lot about risk today in this session. And again, the biggest risk with AI in public health isn't about just getting it wrong. It's sort of how do we use it in a way to improve the lives of the members of our community.
Just if I can add, very practically, what we've done, for example, the hospital, we've established a whole Gen AI efficiency program where we go to department and actually look at some of the kind of inefficiencies that are there and work with them on a very quick kind of turnaround times to use Gen AI to fix some of the major issues, kind of inefficiencies, administrative mostly, inefficiencies, not clinical, administrative inefficiencies. And we do it hand in hand with clinicians and administrators and sort of do this in kind of 2-week cycles to see how we can sort of, remove some of the real inefficiencies in some of our areas and using Gen AI, and we found that that's a very powerful tool for us to move. And with when you look in some of the, we do look at the kind of a impact. Say, my approach to safety around some of these things is I always think about what would happen if the system was wrong 100% of the time. What's the worst that can happen? And typically where we want to end up is if we would just do what, there would just be sort of status quo. Whatever we're doing right now, we wouldn't impact anything beyond, like if even the system is 100% wrong, the worst that would happen is what we do today.
So we've had a number of questions come in related to health inequities, data that exists, historical data. And one of the questions that we had come in, I think, Rowan, this is for you, is what are your recommendations or what's your advice on overcoming the challenge of the lack of historical demographic data?
I think that's a really important question. So right now, any AI tool that is being used is mainly trained on Western demographic data. So there's already so many different organizations that are trying to collect the data from from the different demographic communities, which would definitely greatly help making these tools a lot more equitable. But it's also about just the way that we are testing them. I don't think that we will ever be able to reach like very perfect data. There's ways that you can clean them properly, and there's ways that you can add fairness into the AI models to make them perform more fairly. But we also need to keep reminding ourselves that we need to constantly be checking for this after they're deployed, because data will keep changing, and that means the AI models will be performing differently throughout the years.
That's a really important point is like it's not just a one and done when you set this up at the beginning, but it's something we need to embed in the life cycle of this AI tool or AI solution that we're using, that we need to be thinking about equity on an ongoing basis and performance of the tool. The next question, I'm going to pose this one to Damien. One of our participants has observed that the main challenge of AI in public health is not technological, but educational. And so they have a couple of questions. The first is how can we address the cognitive dependence created by AI in public health training? And the second, how can we also address the superficiality of learning that this generates?
Wow, those are really tough societal questions. I think they'll be difficult to address. We'll have to address as a society. I think what we're finding is that as as we're it's all about practical and kind of usage of these tools. As we're embedding these tools in clinical practice, we are really working very closely with clinicians and how they respond to these tools. And frankly, it's a big research question. I'll give you a specific example. Some of our early warning systems, some of these tools will change their predictions over time. How do you have, we have had nurses who came to us and said, look, these predictions are changing on a kind of hourly basis. What do we do with this? Like, it doesn't make sense. This has to be properly embedded in workflow. We have to be trained properly how to react to this. So once you start embedding some of these tools into practice, you will find challenges that you'll need to address. And sort of generic training will help you kind of build the base for that. But I don't think, really, as that's why we're working very closely with our clinicians and of all sorts, as we're sort of trying to see how these tools are really working in practice. And as Ron was mentioning, it's not a kind of one and done, right? Like, it's once you have these tools in actual, if you do a research project, it's fine, and then you can sort of close it off. But once you have it in sort of practice, you have to monitor these systems on an ongoing basis. But the challenges that you've outlined, as I mentioned, are people over relying on these systems, under relying on these systems are real, and there are no clear answers to that at this point. Like, we're researching those issues actively with our clinical staff.
Thank you. Kyle, I wanted to ask you a question about how open source AI tools such as OpenClaw can be used in public health.
Thanks, Jessica. I really like the idea of having open source, the use of OpenClaw, open source models. You own your data, all of the data sits in your data center. There's a lot of safety and security around that. But what I push back on is that then you're using open models. So you could take a look at Mistral 3, and that's relatively new, but a lot of people are still using Llama 3, which is a year and a half old. And as Damien was mentioning, it's moving fast. So if you're using a model that's a year and a half old for your analyses, depending on your workflows, it might not be the best model. It might not get the best results. So there still is a benefit of looking at closed models when you think of OpenAI or Anthropic's Cloud or Gemini, Google's Gemini, and using some of those systems for certain workflows. But sensitive, repeatable, easier workflows using older models, I certainly think is a great use case, especially in the public sector, if we talk about more sensitive information or somewhat sensitive information being used.
I'm so impressed somebody mentioned OpenClaw.
I saw that come through the chat. I was super happy to see it.
That's great. So, okay, we are coming down to the last couple of minutes of our session. I can't believe how quickly this has gone. I want to ask each of the panelists, just give me like the snippet, the sound bite of when people leave this session today, what do you want them to walk away with? Knowing about AI, preparing for AI, whatever that happens to be, what do you want people to walk away from this session with? So, Kyle, let's start with you.
Thanks, Jessica. I think in short, really quick, using AI, using automation, using technology can make agencies and organizations much more efficient. And I think it's something that as long as you deploy it in a trustworthy way around human in the loop and it to augment staff, I think you'll get a lot of buy-in and a lot of excitement around it.
Thank you, Damien.
What I would say is we've invented all this stuff, and now we're falling behind. So I would encourage us not to be too afraid and to really move ahead with adoption in a very responsible, ethical fashion in parallel, sort of with governance, right? Like, but we cannot fall behind on this. I think it is a serious challenge.
Okay, Rowan, last word to you.
So I'll leave with this. The communities most likely to be harmed by poorly governed AI are the same communities that have historically been underserved by health systems, that have been underrepresented in health data and excluded from the decisions that affect them most. So that's actually not a coincidence, it's a pattern. And AI at scale has the potential to actually accelerate that pattern, or it can interrupt it. And which one happens depends entirely on the choices that the institutions make right now before these systems become infrastructure. Public health already has the values, the relationships, and the mandate to be a part of making those choices well. So I just hope we step into that role.
Thank you all so much. As we wrap up this panel discussion, I feel really excited about the opportunities, and I think you've given us a lot to think about related to some of the checks and balances we need to be really aware of and thoughtful in terms of deploying AI solutions in our organizations. A huge heartfelt thanks to our three panelists for sharing their valuable perspectives and expertise. I can tell by the number of questions that we received. I'm sorry we weren't able to get to everything, but this is definitely an area of interest across all of our participants. And I did note there were some requests for some resources. We will try and get those out to participants with various links after the session. Before we continue on to the next session, we are going to take a 15-minute break. You can join the next session using the second link that was provided to you in your welcome email. And for your convenience, we've copied that information into the chat box for you. Our next session is on misinformation and disinformation. It will begin promptly at 10 a.m., and I hope to see you there. Thank you so much, everyone.